Hi, guys, and welcome to a third episode of Interventions of the Third Kind. How are you
Hello,
doing,
yes.
Sean?
Oh, it's been a busy weekend. It really has. It's been so fun. I'm glad to be back here with everyone. I'm glad to be back here with you. I look forward to our time in the third kind.
I'm actually super excited because we have a very interesting episode today. But before we go into any details whatsoever, we're going to talk about what happened on the job recently. Are you ready for this, Sean?
Absolutely.
Okay, I'm going to start first. Hi there. Today, I wanted to talk about those uncomfortable sounds from the fall season. What am I referring to? I'm referring to the cough, the sneezing, the clearing of the throat, fighting off the phlegm because you did not hydrate well during your shift, the congestion. I mean, don't get me wrong. I know we are humans and this is just human nature. But when quality assurance have to send you an email to let you know that you need to use your mute button more often because you continuously are coughing, sneezing, and clearing your throat on the client's ear, then you need some sort of reminder to help you achieve excellent customer service, stellar customer service. And remember, guys, we're not only interpreting, we are also facilitating communication and providing customer service. So that's why I wanted to introduce to you my friend, Chancla. Chancla has been a tool of excellence when it comes to raising children in many cultures, including mine. My parents, as a matter of fact, use it on me constantly. My mom would just tell me, huélela, smell it, and I would cease and desist immediately. Now, I know times have changed, we have evolved, and instead of inflicting pain with the chancla, I am going to symbolically inflict that pain by reminding you where you need to get better. Okay, how am I going to do that? I am going to do this with the help of a sound effect that will sound like this. And I will do some inflections with my voice to let you know, to emphasize where you need to get better. Okay, are you ready to try this? Okay, so let's do this. Please don't cough, sneeze, clear your throat on the phone. Or if you have an unforeseeable event that you cannot prevent, at least apologize for it. This has been a public service announcement to interpreters that chancla will make you behave. Guaranteed.
Yes, thank you. Let me tell you, this week has been one of those months. Okay, and some of these encounters that I've been in, they felt like one of these weeks. Okay, and I tell you, here's the takeaway, kids. Be careful what you wish for. I swear that is so silly to say, but here you are, right? I'm in an encounter, and everything patient needs to say before she says anything, she needs to have the phlegm suctioned out of the back of her throat. And G was my tablet just right in the perfect place. It's a VRI call. So I'm right at the bed, at the foot of the bed, about 3 feet up in the air, on approach to Flem Central Airport, you know. So the whole time I'm just like, come on, just get through the encounter. And I'm like, yeah, I just want to be done with this encounter. So, okay, we're getting there. Counter wraps up, everything's good to go. Finally, that next call comes in. I'm like, yes. Hello, provider. This is Sean, your Spanish interpreter. How can I be of assistance? And he's like, so let's talk about this ostomy bag's care and cleaning instructions. Yeah. So, here's your friendly pilot on approach once again. So the takeaway here is in the new telehealth world, you know how we were talking about that before, in this new telehealth world, the interpreter is obliged to control that. You need to step in. I want to encourage my colleagues that are on video calls with me to tell the provider, the interpreter speaking, if you wouldn't mind moving the tab a little bit closer to patient so that I can see them and they can see and hear me a bit more clearly. Thanks so much. Because I didn't do that in either of those calls, and boy, I tell you, it was off-putting for me to have to be focused on the ostomy bag and marvel at its transparency. When instead I could have, maybe asked provider and been moved up and give patient a little bit of dignity and etc. So, yeah, definitely assert yourself as soon as, otherwise you don't know what's going to happen. But, hey, that's the nature of this work, right? How was your week?
Emergency, calling doctor interpreter. Emergency, Docterpreter. Docterpreter? So, like we were saying, Sean, doctor interpreters are a very rare species of interpreters, and we know a few, and that's why we wanted to bring them to the show so they can give us their kind of input about this topic that we are discussing today. So tell me, who did you bring?
Absolutely. I'm thrilled. This guest is fantastic. This is absolutely a perfect specimen of a docterpreter, if you will. Dr. Ivan Becerra, native Texan, just finished his family medicine residency and is actually in the process now starting up an emergency medicine fellowship all the way out in West Texas currently. So I am thrilled to have him with us here.
Hi, Ivan. Hi, Dr. Becerra.
Welcome, Dr. Becerra. Thanks for being here today. Thanks so much.
Thank you so much for coming to the show, Ivan, and take some time of your so busy schedule to come and discuss this topic with us about interpreting and being a doctor. You're one of those rare species out there that doesn't exist and nobody knows, but we are VIP and we know. So thank you so much and welcome to the show.
Thanks for having me, guys. Nice to see y'all.
I gotta say, regarding the fact that you're all the way out there in West Texas right now, tell me, is it the way we often think when we think of West Texas? How do you find that area of the country?
That's a very interesting question because, yeah, definitely when I came out here, I had a certain idea of what things were going to be like. In a lot of ways, living out here has lived up to those expectations. It is very dusty out here. That was there are a lot of people with a very different socio-political perspective than what I'm used to. But one thing that I didn't really think about, and I really should have given them more credit, is they've been super friendly, very understanding, and a lot more of that Southern hospitality than I expected. I thought they were going to be a lot more rambunctious and kind of hostile, and they have been nothing but open-minded. And I've actually had, different kinds of discussions with people, and even though we might differ on some details, they've always been very respectful and very open-minded to at least hear my different perspectives. So yeah, it is a little, rough out here sometimes. We see a lot of people that, might not have the best education, don't really take care of themselves from a medical perspective. But everybody's been very kind and loving. And you can tell that, as kind of spread out as the community can be physically and geographically, they're really together as a community that I didn't expect that. I tend to think people who are more spread out and isolated might not come together as much. Nah, but these guys really pull together, and it's, they're very helpful. They're a lot more pleasant than I maybe gave them credit for, but that's just served as a lesson for me to be a little more open-minded as well on my end.
So let me ask you, regarding your current career and your career path, as it were, I'm curious, were you an interpreter before you were a doctor? Were you a doctor before an interpreter? Are you simultaneously both? Tell us a little bit about that.
Yeah, actually, I ended up being an interpreter before I became a physician. I kind of fell into interpreting and never really expected that to be part of my career path or my plan or anything. but I lucked out in being accepted into the community because it's actually taught me a lot. So I, after medical school, I ended up having a few years off and was looking for something to do in the health, arena. And at the time, I couldn't really practice. I didn't have any sort of extra training besides medical school. So that wasn't going to be an option for me. And then just looking around, I knew some people kind of second and third hand that were interpreters. And I found out that they had, job opportunities available. And I was kind of welcomed into that niche. And it wasn't until after I worked as an interpreter for a few years that I was accepted into further training for medicine and kind of followed through with that. So yeah, definitely an interpreter before becoming a physician, and lucky to have had the experience because it's definitely helped me out a lot in dealing with my patients, communicating with them, making sure that there's better understanding between people on our side of the desk and the patients on the other side of the desk, especially when we have a pretty diverse community out here and a lot of Spanish speaking. I was a Spanish interpreter, but also, several other surprisingly pretty diverse community out here, pretty large Indian and Asian community, though one might not expect that.
So, Ivan, let me ask you, when it comes to, you were an interpreter first, and now you are a doctor and are, specializing in other areas. Do you think a person can do both? And where is it that you draw the line?
Yeah, that's another good question because, again, kind of growing up in like a biracial or bilingual environment, it's easy for me to think that, at any point it's appropriate. I want to help out. I'm going to do my best, but, and it's okay, right? That's what I used to think before I became an interpreter. But, having gone through my experiences as an interpreter, I realized that there's definitely areas where one should not do both. And the way I kind of imagine it is there are certain circumstances where a certain treatment modality or treatment plan is appropriate, but it might not be the best. But depending on where your situation is, where this case is being handled in one hospital versus a clinic, a big city versus a small city, you might have better options and better alternatives at your disposal. And if you do have those alternatives and resources, then that maybe kind of it'll get you by solution is no longer appropriate. You have to tailor your interaction and your ability to do one or the other or both, depending on the resources available. So I do believe that one person could do both, but if you have the resources available to where you don't have to, I think that's definitely the best approach. And I do believe that there need to be more resources dedicated to interpretation across the board, man, because there needs to be more access to interpretation and to facilitate communication between the patients and the medical staff in the hospital versus different other settings as well. So where do I draw the line? Unfortunately, there's no hard or fast rule for me because it really depends on where I'm practicing. If I'm practicing, for example, in a larger community with a big facility that does have interpretation resources, then there's no excuse for me not to use them and to definitely delegate that role to another individual where that's their purpose. If I'm in a place that maybe doesn't have in-person interpretation and they have electronic means to interpret, then ideally one should be able to use those resources as well. But I've definitely found myself in a small community hospital in the middle of the night, dealing with, not English speakers. And I've definitely found myself in a situation where their only access to communication is through me because the people I work with aren't interpreters or I don't have those other modalities at my disposal. So where I draw the line, unfortunately, there's no easy answer to that other than I draw the line to where the resources that are available to me allow me to draw that line.
Certainly
It
does.
makes all the sense in the world. And that was going to kind of be my next comment to you. I mean, but obviously your focus when you are in a room, your focus as a doctor, right? And you want to provide that patient with the best treatment. But when you have to do doctor, be an interpreter at the same time, and then if building those relationships, because like you said, you are in a small community that doesn't have that many resources, and you kind of become their advocate at the same time as well. So there is many things involving that kind of process. And to me, is at some point that can affect, other things. You know what I mean? Because you're
Absolutely.
not just focusing on one thing.
Right. And one thing that I don't know, people seem to forget sometimes is that, yeah, being this weird blend of interpreter and physician, we have almost like a dual legacy towards advocate for the patient. We as healthcare providers should also be advocating for our patient. We as an interpreter should be advocating for the patient's care. But I was thinking about another case that I had maybe 2 weeks ago, where it was the middle of the night. I was in the emergency room seeing several patients at the same time. It was towards the end of my shift. It was a pretty tough shift, and I had the distinct memory of blanking out on a specific term, and I was trying to communicate a very complicated idea and concept to a patient, trying to get them to understand and buy into why we were treating them a certain way. And as I was coming to the crux of the whole thing, I totally blanked on the specific term that I needed to communicate. And on a personal level, it was very frustrating to me, and it kind of bugged me. On a professional level, it's unprofessional to seem that way in front of a patient. It's unprofessional also to have the patient unsure if I, as a provider, am really knowledgeable on what I'm talking about. It gives kind of an unprepared air or appearance to my care. And at that moment, I really did wish I had an interpreter, albeit that I've been, both in the past or currently am the doctor. I'm advocating for my patient, wanting them to understand what we're doing and why. But definitely, there is a point where your head cannot encompass both roles. That's not even speaking towards the ethical, conditions that come
Right,
with
right.
it.
Any possible conflicts of interest or perceived
Exactly.
thereof. Exactly. I get you. I get you.
Exactly. So yeah, even from a physician's perspective, I definitely would like to have, in that case specifically, um, kind of outsourced that, cognitive burden to another individual where that's all they're focused on. That way I can focus on the clinical aspects. I can answer the patient's questions and not worry about whether or not they're understanding what I'm trying to say just because I blanked out on a term that I should have known and been able to deliver.
Well,
So definitely there's
Ivan,
a
but you
difference.
are also a man. You're not a
I was
superhero.
going to say there's
Okay?
some validity to that point. You can't expect to have full command over both crafts
Yes.
simultaneously. So,
Especially
Yes.
under duress, depending on the
yeah,
circumstance of the case, like being in an emergency room, we see all sorts of acuity levels. And it's one thing if somebody comes in with sniffles and bumps, and you can take your time. But if you have three people that are in difficult situations, you don't necessarily have the time to look it up, to fumble around words,
no,
and it
absolutely
definitely
not.
gets in the way of your care.
I bet that as a doctor, I'll tell you what, as an interpreter, let's start like this. When I walk into an encounter where I'm confident with the material, I'm very accurate with my renditions, and I'm very comfortable with controlling the flow of conversation, interpreting and being that conduit, right? So I'm
Yeah.
going to assume that because I'm sure you can identify with that feeling yourself as an
Hmm.
interpreter, I'm going to assume there's something similar when you walk in and you just doctor the hell out of that encounter. You know what I mean? So
Absolutely.
with that point, knowing that, it's either one or the other, assuming that you're a fantastic interpreter and also physician, I would say, and again, with respect, I would think I and 99 other people out of 100 would prefer our doctor to be 100% doctor at this time. You know what I mean? You go help another guy, I get you. But I think that's I mean, again, not to go so far as to paint this and say this is a poignant episode, but I think that has to happen for a docterpreter in that career path, okay? Especially because you were on this point to help this patient, you know, and then you realize I was up until this moment, whatever this term was, and then now I realize, but the beauty, and I want to commend you, the beauty here is that you walked out of that not saying, gee, I wish I had studied that word. No. You said, I realize now that I should have had an interpreter there, which means you will, and you do, you know. So that right there is where I feel like the biggest lack in any kind of medical schooling is that which is the import to access to communication, as you mentioned yourself. And
right. And to kind of piggyback on that, like, of course, there's going to be a part of me that's going to be an apologist for the rest of the doctors, but the career selects for people who are independent, people who are problem solvers, and people who are confident in their capacity to do those things. So yeah, in an ideal situation, I agree, we all should be a lot more cognizant of our own limitations, but also as a culture and as a community, we're also selecting individuals that are going to just try to work with what they've got, whether or not they're including other resources at their disposal. And I think the problem comes when a person, whether they be a physician, an interpreter, or, you know, whomever else, when they don't recognize and aren't honest with themselves as to where their limitations are. And I think, unfortunately, sometimes we're so task or goal oriented into thinking like, I'm going to have this patient walk out doing better, that you don't really think about all the other stuff that is included in feeling better. Yeah, physically they can walk out with, you know, feeling better, but are they better understanding their situation? Are they better being compliant in their medication regimen? Like, are they better all around? And, you know, like you said, we can't wear all the hats all the time. And it's easy for us to forget that, because in that situation, we're called upon to at least appear that way, you know? And if you don't keep questioning yourself and running those things through your own head, it's easy to stop doing it. It's like any other muscle. You have to keep working at it and hold yourself to the standard that you would like to be accountable to. And sometimes that's a tough conversation with yourself, and other times it's not. But if we never question ourselves, we're never going to know where we stand, you know.
I want to jump in on questioning, okay? And this is the Bill O'Reilly moment. This is the gotcha moment, right? This is because you talked about the questioning, I wanted to take you to a place, okay? When you were as an interpreter, especially like right on the cusp of beginning a medical career, when you, I'm certain, were studying fervently, okay? So we'll take, and that's also going on the assumption that you aren't actively interpreting with any kind of regularity at this point in time because you're practicing doctor. Thank you very much. So for my point, you are a interpreter. Okay, it's a difficult hypothesis, but just for the point, just contort yourself imaginatorily here. Okay, my point is, you're in an encounter. You have this knowledge of a burgeoning medicine, and the practicing physician, whoops, you see something that is, I can't believe you are. It's very clearly not that. That is not the diagnosis, madam. What are you thinking? You know, in your mind. Of course, you sound like me in your mind in this hypothesis. Right. So, with all of that, give me your Dennis Hopper. What do you do? What do you do?
That is a good, albeit a very tough question to answer. And, you know, thinking back in my career as an interpreter, I can't think, thankfully, of a time where I saw or heard a misdiagnosis in the room. I can't speak to that, unfortunately, but what I did see plenty of times was definitely a miscommunication of what their diagnosis was. So I know that's not necessarily the breach in communication that, you know, you're asking about, but it's definitely one that has, you know, very similar implications Because even though you have the diagnosis right, like what, to be coarse, like what does it matter if the patient doesn't understand what that diagnosis was, or if they misunderstand it completely and think something else entirely? Either way, there was a breach in communication, and either way, unfortunately, it's a fault of the practicing physician if they're not checking in, or the healthcare worker, if they're not checking in with the patient on whether or not they understand what was communicated to them or not, which often is the case, where they deliver their payload, they turn around and walk out of the room, and the patient is left still with the question box over their head. And
Okay,
then
I'm throwing this at you now. Here's the flip side. Okay, what do you do, Dr. Becerra, when an interpreter makes an error with one of your patients? What do you?
so so unfortunately, the places I've worked at don't have interpreter
Oh, I was going to say, woe
resources.
betide he who makes such an error in these realms. That has
But
it.
look, so I think both ways. Well, as a physician, because if I'm speaking in a language other than English, I'm always careful to ask the patient, what is it they understood? Like, what made sense? What didn't make sense? Now you tell me what I just told you in your own words, so I can grasp what it is that they understand. And the other case, so there are ways you can the ways you can judge a person's comprehension through the conversation and in the encounter as a physician or as a caretaker. Um, and in the other case, I definitely have been known to, once we've stepped out of the room, to ask the doctor, hey, I'm not entirely sure if they understood. You might have to edit this out because this is confessions of an interpreter. I've definitely asked a provider um, if they think that the patient understood, and I would definitely voice to them as an advocate for the patient, I don't think they understood what you were trying to say. And I'll ask them, they can come back in with me, or if they want me to do it and then come back to them, I've asked them, do you mind if I try to explain it to them the way I think you were trying to tell them? And then break it down a different way, and then have the provider still there in case the patient then has questions. And then I can slip back into my interpreter role and purely do that. So similarly, while I as a physician would do is ask them, does that make sense? I always have does that make sense? Anything that was unclear? And then once they tell me no or yes, I'll tell them, can you tell me what you understand? And then I can work on bridging whatever, problems there were in my communication.
Now, the difference is that a lot of people, at least a lot of my colleagues, tell me that I'm out of line by asking the provider to do this, that any provider who's worth their salt, present company included, of course, is going to go out of their way to do this on their own.
That is not the case. I've seen it plenty of times where they don't. And it's unfortunate. And I don't think it's malicious most of the time, but it's just, again, like I said, they've delivered the message, they've stumped their speech. Now it's time for them to sign off and move on to the next case. But still, again, we talk about being advocates, both as healthcare providers or as interpreters. And I think that's definitely something that needs to be at least entertained, if not actually executed on, and done.
I was actually going to ask you something very particular because one of the things that I don't like as much as an interpreter is when I am in the middle of an encounter and a doctor asks me if they can practice their Spanish or their wording or stuff like that. Listen, I am up for people to learn the language. I don't have any problem with that. But my problem is that we are in front of a patient. This is not, I mean, I'm doing my job. You do your job. I would never ask a doctor, let me go and practice a little bit of surgery because I've been thinking about becoming a surgeon. I mean, I just want to put that out there and ask you particularly about that because I have seen it lately happening more than often. And I have seen it in big hospitals and I have also seen it in small clinics.
Right. So yeah, I think that's a huge overstep. I am not, and trust me, as an interpreter, as a resident in training, and as a physician in one room hearing a conversation in the next room over, those are my ultimate cringe moments, is when somebody who thinks they've got their stuff on lock tries it and just is absolutely awful at it. And yeah, I've never cringed the most besides those situations. And yeah, the way I see it, the patient is there to get better. The patient is there often under duress. That's their time. That's not the provider's time to practice. And that is, I think, very inappropriate, especially if you have an interpreter there to do their job. I think that's both an overstep out of their role and very insulting to all other parties involved. I don't agree with that at all. It makes them look awful as well, makes them look unprofessional, and it is not a good look for that provider. I would definitely recommend most people do not do that. Yeah, like you're saying. Now, if outside that encounter they have a question about terms used or ways that things were communicated, sure, that's now the doctor and the interpreter's time. That's not patient time. That is not patient care. That's, you can ask questions there. You can practice in dialogue with the interpreter at that point, but never during an encounter is that time to practice on whether or not you can say or interpret competently. That's what other things and other settings are for, definitely.
And
You
to
know,
me, it
good.
all falls along the same category because, for instance, I, I've been in, doing consents with a doctor patient, and the doctor says, I'm gonna just say, well, I'm gonna do this in Spanish, and you tell me if I said it okay. But then they ask you for your ID as a witness for that consent, and I'm thinking, listen, I am here to interpret.
That's the
And if
witness.
would you like me to, get your ID so I can prescribe some medication? I
Yeah.
would never do that.
Yeah, I think that's poor culture and poor education on their end. Yeah, whenever I hear that's okay, I think I've got this, that's my like, that's the equivalent of no offense. Like that's always the preface to a conversation that I
Something
don't want to
offensive.
hear.
Yeah. I
Yeah,
don't want to
like
be
that's,
racist, but
yeah,
say
that's
something
just
racist.
bad news. The rest is just gonna make
Oh
you
gosh, yeah.
cringe.
Oh,
Yeah.
yeah. Anybody that wants to, yeah, that's perfect. Yeah. Any kind of warning for a statement, oh, okay, it's yeah. Even
And
something
then
that says,
that,
with all due respect. No, there's no respect.
yeah, and what's bugging me about that the most is that that reflects a recognition on their part. Like they know that there's something not right,
Yeah.
like, because otherwise they wouldn't have to preface it. That's what's the most mind-boggling of those interactions sometimes, is you obviously know that you're not in the right, otherwise you wouldn't address it. You're addressing it because you're asking me for implicit permission to continue doing this, whereas and you don't necessarily have that platform to tell them no. And
And not to be rude, but this is somebody else's health. Excuse you.
Yeah.
exactly right.
Yeah.
Agreed.
Yeah. I've always wanted to break out something crazy. Like I've seen every season of House.
Yeah.
Okay. I'll have you, why don't you stand over there and jump in when I need some help?
Well, it's like our version of Dr. Google, right? Like
Yeah.
when somebody comes in and says, I have these symptoms, and Google tells me that I
I've
have
got
this
this.
diagnosis, it's the same as a provider coming in and saying, Google Translate told me that this is what I'm trying to say,
Yes.
and that's inappropriate in both settings.
I was just thinking, do you want Google to be your doctor?
I mean,
No.
we might get there in 10 years or in 5 years, but like not now.
Not currently, not that Google anyway.
Yeah,
Maybe the
that's
secret
exactly
Google,
right.
the space
Yeah.
Google, that
Yeah,
might.
space Mars, Elon Musk Google.
Yeah, exactly. Skylink Google.
Any recommendation for interpreters, Ivan, since you were an interpreter first?
I have a few. So first things first, I think in the vein of open communication and building relationships and forming alliances, I think both ends, I think on both sides of the megaphone, we gotta be patient and be open-minded and give people the benefit of the doubt. Like one thing we have to understand is these providers, they've spent their whole lives acting a certain way, or they have it in their head that they're capable of doing certain things. Just like educating a patient to change their diet once they're 60 something and had their first heart attack, it's going to be a difficult run. So be patient. Understand that most providers are not doing this out of malicious intent or to denigrate or degrade your profession as an interpreter. No, often they're doing it out of innocent wanting to help or trying to be better or more efficient and trying to be cognitive of limited resources. Oftentimes they're just trying to get the work done quickly and not necessarily wanting to form those barriers to communication. So one thing I would definitely recommend, both for providers, but in this case, interpreters, is just be a little bit open-minded and open dialogue. Talk to your providers, tell them kind of where you're coming from, be nice, be understanding, and oftentimes they'll listen, they'll want to do better by their patients. If you frame it in a context of patient care, they're going to be more receptive. Don't tell them they're being bad or they're doing wrong. Tell them, I think the patient would benefit from X, Y, or Z. And a good provider worth their salt is going to listen to that. So I would say that, to start with. I think another thing that would be great, for interpreters to do is recognizing that just like medicine and language are living, breathing subjects and bodies of knowledge, we also have to keep on our game as an interpreters. Learn, study, be curious, ask questions of your providers, ask questions of your own interpretation skills. If you've done a written translation and you're not sure about certain terms, look into it. See if there aren't any readily available translations. Look into the procedures. See how there's a way that you can try and communicate whatever it is that you're trying to communicate for the next case. I definitely think being curious, no matter what career you're in, is always going to give you a longer career. It's always going to help you feel more fulfilled when you're done, when you've done a good job rather than just a fast job. I would say those things are my recommendations for interpreters.
I am super, 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 super happy, Ivan, you decided to take the challenge of coming to our show and talk to us about this topic. We really appreciate it. We wish you the best of luck with this new residency in ER. Oh my God, I want to do the series. I will produce them when you get a contract on TV.
That's what's up. I'll keep you guys in mind. Thanks for bringing me into the interpreter pit.
And I wanted to introduce you to Dr. Fabian Robles. Fabian, or Dr. Fabian Robles, is a doctor from Caracas, Venezuela, but he has also been a former colleague of mine. Fabian also has been an interpreter since 2011, but he has been a certified medical interpreter since 2016. Fabian has also experience managing a language department in a healthcare setting. He's also part of the executive board of the Texas Association of Healthcare Interpreters and Translators, and he has a master's degree in healthcare leadership and management from the University of Texas at Dallas. So without further ado, here is Dr. Fabian Robles. Okay, hi Fabian. Thank you so much for coming to Interventions of the Third Kind. How are you doing?
Doing great. So thrilled to be here, seeing you guys again. Lorna, Sean, hey, it was a pleasure to work with y'all in Austin.
I'm so excited that you decided to come to participate in the episode, because we are talking about the rarest kind of interpreters, which is the doctor interpreters. And I have the privilege to met you when we were former colleagues back then.
Yeah.
And I thought about you immediately to come over and talk to us about this topic that a lot of people doesn't talk about, and really they don't, because I guess they don't go into it. They don't have kind of the interest in it, but it has always it's always been a topic that really interests me a lot. So what came first for you? Was it interpreting or was it medical, being a doctor?
So everything started for me in Caracas, Venezuela. So I'm a physician in Caracas. I graduated in 2007 from the Universidad Central de Venezuela. Then I worked in the emergency room for approximately 2 years, from the internship until I moved to the United States. And the decision to move, it was because of the economic and political hardship that Venezuela was having at that time with President Chavez in the power and the radical communist ideology that they got. So in conclusion, we basically, like any other immigrant, we decide to move for a better future.
Mm-hmm. Here, here. Well, here's what I'm curious about, Fabian. I don't want to necessarily just throw out something like why, okay, but you know, we're recognizing that you're at this moment now a practicing, or at least you have worked as an interpreter after you arrived here. I'd like to hear how that ended up happening. I mean, did you? A lot of times people realize, wait, this is a thing.
Yeah, and actually, it happened to me too. So the profession, it found me. The story goes is I was working as a medical assistant in a medical practice, family practice in Austin, and a patient I was seeing learned that I was a foreign doctor, and he mentioned the opportunity to be a medical interpreter. So I make that bring me curious, like bring the bell, and so I started looking around the hospital about this profession, and I found a job as a PRN in the pediatric hospital. And then in that job, I was able to help the most vulnerable patient to communicate in the most critical time they're being when they're looking actually for help. So that's what time actually I felt again engaged with patients, and I was motivated the first time I became a physician.
So, Fabian, let me ask you, what is your thoughts about interpreters from a doctor's perspective?
So, from a bilingual doctor's perspective, I can tell you that interpreter's job is very vital in the healthcare. I can make difference between a good and a bad outcome for a patient when actually they use a medical interpreter. So a well-trained interpreter, what we call qualified interpreter, can identify factors involved communication, not only the verbal cues, also the body language, cultural component, and biases that exist in the community. And those things are most identified that definitely help the patients to understand what the provider are telling them. So this is our serious talk about healthcare reforms currently right now in the United States, especially in quality service delivered. So what I mean with that is the hospitals and government institutions like the HHS and the CMS are looking how to resolve the cause of death, the third cause of death in the United States, that is medical errors. So we're talking about 440,000 deaths a year for medical errors. So there's studies around showing that actually patients, they are limited in English. There are 3 times more to encounter a medical error. So you can see how well-trained medical interpreter can make the difference.
Let me ask you this. I mean, as at least I like to consider myself a well-trained interpreter, but I certainly have seen the let's say the ad hoc used at times that can really be dangerous. Now, because of the fact that you have this prior entire profession of as a practicing physician back in Caracas, so now as an interpreter, I'm curious, do you think that it, again, we've established the uniqueness of the, as I call them, Docterpreters, right? But my question is, do you think that somebody can do that? Can you be your own interpreter as a physician? Could you do this?
So well, that's a great question, John. What I believe that it's possible to do both jobs. In some things where actually we need to be clear is what hat are you wearing at that time? When you're serving as interpreter, all the bias and personal opinion have to be locked away. And you need to be very clear that the job is conduit and accurate information, even though if you disagree or not with the information given. It is for sure the fine is a fine line because it comes as a second nature if you're a well-trained interpreter. So that's the difference.
That just jumped right into my mind. Okay.
Yeah.
Because again, we're putting you as the fact that you're obviously well trained. You obviously are a well trained physician as well. So when I want to applaud you for pointing out the impartiality piece, because that in itself is extremely important. I mean, really, to me, it's more of a protection because I can just distance myself from whatever is happening in the encounter and just go all out on it. But so where do you draw the line? What if you witness something that you have a problem with in one place when you are performing the other? You see, if you are in wearing one hat, but you see there's a problem going on the other side.
So in my case, the particular when I see there is a misconduct or something that maybe because there's a cultural aspect of the encounter, once the encounter ends and we step out of the place, that's the time I approach the physician or the nurse or the provider. They can include nurse practitioner or physician assistant.
Sure.
And then I make them aware of what might be happening, because there are cues that an interpreter, a trained interpreter, a qualified interpreter can get that actually maybe the physician or the provider might not get on the encounter.
Let me ask you, when you have been an interpreter in a room, I mean, you're a doctor also, you have all this knowledge from medical school and all this, right? In your residency in your country, right? Yeah. Previously. So you are in a room and you hear a misdiagnosis. I know you are an interpreter at that time, but you know, as a doctor, that is not correct, you know? Do you say something? I mean, do you do something? Do you say, okay, here I have to say something? Or when, I know as interpreters we are just supposed to be the conduits, but when you have knowledge about something, it's what do you do in that case?
So and for a certified interpreter in the medical field, it is on your duty if you see something to say something, because there's the conduit part, and then you go to the cultural awareness, and then you go to the advocate. So yes, you should say something and you see something. Now, if the mixed diagnose itself, you can actually, and if there's something else going on, you can have it outside of the room. Don't have it inside, because now it becomes your word against the physician. So there is a credibility part that had to be between the patient and the provider. So far in the many years I've been working as a medical interpreter here in the United States, I have not encountered any misdiagnosed. Most of the time, what I found is kind of a frustration when working with residents and medical students. They're asking patients and parents questions about their entirely unrelated to the case. So sometimes even you ask yourself, like, well, seriously, like what you're doing here? And sometimes even attending, asking questions to the residents and students or in rounds, and actually you're kind of like, I know that question. It's like, ask me because I know. You know, so I got a quick story about, so I was in the cardiology area in the heart center, and we were in rounds, and they were asking a question about an EKG. And they were asking to a student, a medical student, and I noticed that he froze. And when I started whispering the answer to his ear, so but the attending caught me. So I and then actually answering the question for the time round, you know, and in the funny that actually was the station interpreter answering random questions, clinical questions to the medical, you know, and so everybody started laughing, we were laughing, and then we continued around. But you can see that one of the things that happened in that area is I was a station interpreter. So I built some rapport with attendings and the team, and then they knew my background, that I was a physician. So that's kind of the difference when actually you know your physicians, you know your team, they know you. It makes it easier when you approach them. They'll be open. I feel very difficult in the case if you are a vendor. You know, if you're from a company that comes and the team doesn't know you, the provider doesn't know you, never work with you, I can feel it like awkward to actually have to approach the physician. So it can make it a little bit more difficult.
So what I want is I want your recommendation with your knowledge, with your viewpoint. I want you to speak to all the interpreters out there. What's your recommendation?
So first thing I would say, get certified. You need to get certified. Study hard, be prepared, read, ask questions. Don't be afraid. Interpreter is a booming profession, and it requires getting challenging. And being competent and certified is the best tool. So the work of medical interpreter is truly helps to save lives, and you can really make the difference on quality of healthcare. So especially if for those limited English proficient patients, you know, so we can make the difference for them. So we need to start the conversation also in the interpreter to be specialized, because as you know, you don't see the doctor being specialized in all the areas. So the doctors, nurse practitioner, physician assistants, they're focused in organ systems. So their expectation for the interpreter is they're being proficient and familiar with the terminology used in that specialty. So the third recommendation I would say is join your local interpreter or translation organization or association. I'm part of, you know, I'm from part of for the Texas Association of Healthcare Interpreters and Translators. So I'm one of the secretary board members. So we as an organization, we're looking for provide education and work also in legislation to change and promote development of the profession. So do those three things, and actually, I think that will improve your workflow, improve your career, and actually the profession itself.
And you know what, Fabian, I'm glad you mentioned that part about, specializing, in something,
Yeah.
because you're not supposed to know everything. And the other day, I'm also a translator. So I was translating a discharge order, and it was an abbreviation. I've never seen that before in my life. And I'm
Yeah.
thinking, I asked my coworker, am I supposed to know this? I mean, I feel like I have never seen this. I cannot tell you exactly which one was it, because it's been one of those months, there's been a lot of people sick and all that. But I mean, it was, from another colleague, it was expected of me to know it. And I'm thinking, no, I don't, I should not know everything, because I didn't go to medical school. I didn't even go to school for, I don't know, to learn tachygraphy, which was the first, way of taking notes for medical, interpreters or medical people, doctors, all that type of thing. So I was like, no, I'm not supposed to know that. So I'm glad you mentioned that, because I
Sure.
felt kind of baffled about it.
You don't feel bad because neither doctors. I'm a physician and I don't know everything. So my uh, 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 part of the expertise was in emergency room. But if you pulled me to ophthalmology, wow, even I struggle.
Sure.
So you see nurse practitioners, you see physician's assistant, they stay on a specialty. So why we have to go around all of them? So and actually they're very specific. So for example, let me go up with again with the cardiology. They're so specific with cath labs. They have different tools that actually you have to explain the consents. No, they have specific for heart transplants. So that actually you need to have treatment, medications. They are actually only for transplant patients. If you're not used to those medications, you get in trouble when you're interpreting. But if you're used to, you're always working with the same team, same provider, same medications, you know the flow. They say it is a second nature. They feel the physician will say, everything we've done, of course, because we're doing it over and over again. So that's why we had to start that conversation. So we should be specialized too. We're going to specialize in ER. Should we specialize in GI? Should we specialize in cardiology, neurosurgery, transplant? So there's so many things, so many aspects of the anatomy and the medicine that one interpreter cannot take all over. Oncology, cancer patient, radiation oncology. So I can give you a list of things that actually, even me that went 6.5 years to school for medical school, I don't know.
I really appreciate your time, Fabian. I so appreciate this because a lot of times, as interpreters, especially when you just join and start doing it and know all the other possibilities you can have, or you can have available to go through as an interpreter, we need guidance. And sometimes we don't have that when we are working remotely, most of what we're doing nowadays. So I really appreciate you taking the time to come to the show and give us your input.
Hey, no, thank you so much to think about me. When I got your email, I was like, she's alive. And then I went to see your first video, and then it's like, Sean is also alive, and he has a beard. What is that? Like, that was amazing. It was a pleasure actually to be here with y'all.
Hi, this is the interpreter speaking. Hey, colleague that thinks that you need to change the register to a simpler version and deliver the message from the provider using word pictures because you don't think that the LEP is going to understand that complicated terminology? You're wrong. When you take away the patient's dignity and you remove their autonomy to ask their provider, what does that mean? Because from what you've seen, or in most cases you hear over the phone, or in reality, you've assumed that this person won't understand this term, you feel that you need to leave the conduit role and alter the original message. Well, I got news for you. You're wrong. You got one job. You hear it, you render it. Let the provider take care of the patient. Let the provider be the one that makes sure that the message was understood. Okay? They're the ones that can use the teach back. You take care of the interpretation. Okay? Another PSA from your friendly neighborhood interpreter. See you next time. Thanks for stopping by, kids.